Start. Good afternoon, respected faculties, my seniors, and my fellow colleagues. Today, I'll be presenting the case of proptosis. I'm Dr. Vaibhav from Unit 5. The preceptor of class is Dr. Rachna Meel ma'am, and the moderator is Dr. Neha Yadav ma'am. So, I shall be starting with the case. The 30-year-old gentleman came to the RP center with a complaint of outward bulging of right eye for 10 months. The bulging was gradual in onset and the progression was slow and continuous. So as the onset is gradual, it points out towards the etiology being tumor or any lymphoproliferative disorder. And the progression being slow and continuous also points out towards the etiology being tumor. So there were no complaints of pain, redness and flashes. No history of trauma was there. No history of any major surgery was there. And no history of allergy to any known drug was there. As it was painless, as it was painless, there was no redness. It likely points out that etiology is not inflammatory or infectious. Apart from that, no history of any major surgery. The point behind asking this was that there can be metastasis from primary cancer like lung or breast. So if there is no major surgery of any lung or breast, we can rule out, or we can get a clue that it's not a metastasis. On general examination patient was afebrile with all the vital parameters being within the normal range, as pulse was 77 per minute, respiratory rate was 14 and BP was 124 over 77 mmHg. Sleep was adequate, bowel and bladder habits were regular and normal. There were no gross abnormalities in the cardiac, respiratory and GI examination, and no focal neurological deficits were noted. On the proptosis workup, on the inspection, there was definite facial asymmetry noted because of the protrusion of the eye. So there are two methods we can see the protrusion of the eye. One is Nafziger's method and second is the worm's eye view. In Nafziger's method, patient is being seated on a chair and the examiners come behind the patient and look from up to see and notice any bulge from either of the eye. In worm's eye view, the examiner is standing in front of the patient and patient rotates the neck and faces upwards and the examiner sees from below. Abaxial proptosis was noted as the globe was pushed outwards and little bit downwards. On Hertel's exophthalmometry, the distance between two lateral orbit rims was 102 mm and distance from the orbital rim to corneal apex in the right eye was 23 mm and in the left eye was 16 mm. There was also 5 mm inferior dystopia was also noted. So dystopia is basically outward protrusion of the globe. So on palpation, no orbital mass was palpable, no lid fullness, no pulsations were noted. There was firm resistance to retropulsion. So resistance to retropulsion is a test where we push the eyeball behind with our fingers and notice the consistency. If it is soft in the consistency, it likely points out towards the hemangioma or any vascular abnormality. And if it is firm, it points out towards a solid mass. It points out towards the tumor or malignancy. So on ocular examination, the distance vision in both eye was 6.6 with PR accurate. Vision is very important because if there is loss of vision, it likely suggests that there is optic nerve compression, which can be because of proptosis. The IOP intraocular pressure in right eye was 16 and in left eye it was 14. Increased IOP can be seen in thyroid eye disease. On refraction, in right eye, The spherical power of 0.75 was given, and in the left eye 0.5 diopter was given. There was no chemosis on the examination of conjunctiva. There can be chemosis in the cases of inflammation, and the cornea was clear. Anterior chamber was normal with VH4 grading, and no cells and flare were noticed in both the eyes. If there are presence of any cells or flare, it can point out towards the inflammatory etiology or infectious etiology. The pupil was normal, 3 mm, which dilated to 7 mm. It was central, circular, and it was reactive to light. Lens was optically clear in both eyes. On fundus examination, glow was present, media was clear, cup to disc ratio was 0.4:1, NRR neuroretinal rim was healthy, AVR 2:3, and foveal reflex was present. There were no peripheral treatable lesion was present. The differential diagnosis can be benign, such as pleomorphic adenoma, as I described earlier, that it could be lymphoproliferative etiology of lacrimal gland. The etiology can be malignant, such as adenoid cystic carcinoma, adenocarcinoma, which is unlikely in this case because it was a gradual swelling and the course was slow and continuous. Inflammatory lesion can also arise in the location that was patient having. It could be pseudotumor or sarcoidosis. On baseline blood investigations were also performed, which came within the physiological range. Hemoglobin was 15, and total leukocyte count was 10,000 to 30 per cubic millimeter. CT head and orbit was also performed. On CT scan, this is the coronal section showing mass lesion present in the superotemporal region of the orbit, which is pushing the globe downwards, and it is also causing some bone remodeling and fossa formation. So diagnosis is most likely right eye abaxial proptosis, and we planned right eye lateral orbitotomy with tumor excision. The discussion part would be discussed by Dr. Shilpa ma'am. Thank you.
Good evening, everyone, respected faculty and my dear colleagues. I am Dr. Shilpa and I will be proceeding with the discussion of the above presented case. So, we have a 30-year-old male who presented to us with complaints of unilateral planeless progressive abaxial proptosis for the past 10 months of duration. On examination, we could find that his uncorrected visual acuity was 6/6 bilaterally, extraocular movements were full, and the lesion was non-tender. There was mild to no resistance to retropulsion. Anterior and posterior segment examination were within normal limits, and there were no regional lymph node involvement, and systemic examination was also within normal limits. So based on this history as well as clinical examination, we can get into four major differential diagnoses. The first one would be a lacrimal gland tumor. As all of us know, lacrimal gland is located in the lacrimal fossa region, and a growth in that region, if it is overcoming the size of the lacrimal fossa, it can cause a medial displacement of the globe, and if the lesion is extending beyond the equator, it can also lead to proptosis. And the second differential would be a orbital schwannoma, which is a peripheral nerve sheath tumor, which is usually seen, it can be seen in association with neurofibromatosis type 1, and usually seen in middle-aged females. And here also it presents as a lateral orbital mass which can extend up to the orbital apex. The next DD would be a posterior dermoid cyst, which is the orbital dermoid cyst. It is different from the angular dermoid in the way that angular dermoid presents early in early childhood or in the adolescent period, But a posterior dermoid usually presents in the second to third decade of life, and it can cause proptosis as well as can present with symptoms like diplopia. Other DD would be a mucocele of the frontal sinus, which can cause a downward displacement of the globe, as is seen in our case. And in that case, the patient would have other symptoms like symptoms of sinus involvement. So keeping all these DDs in mind, we had ordered for a non-contrast computer tomography of the patient, and these are the findings we could see. We can see that there is an oval to round, well circumscribed lesion seen in the extracorneal compartment of the eye, located in the superotemporal part of the orbit, in the lacrimal fossa area to be precise. And we can also see that comparing on either sides, there is some amount of bone remodeling that is caused by the tumor, and we can also see that there is no bony erosion or bone destruction or calcifications seen in this case. So, considering the history examination as well as the clinical radiographic finding, we can bring our diagnosis, differential diagnosis, to that of a lacrimal gland tumor, which is seen to be arising from the lacrimal fossa. So here, our next step would be to distinguish between a benign or either a malignant tumor or other tumors like lymphoproliferative lesions or inflammatory lesions of the lacrimal gland. So our first DD would be a pleomorphic benign tumor based on the CT as well as the clinical presentation, and the most common of which is pleomorphic adenoma. It usually presents in the 4th to 5th decade of life, and the tumor can cause a downward as well as inward downward and medial proptosis, as I've already told. And the CT findings would be a round to oval, well circumscribed lesion which causes the enlargement of the lacrimal fossa without invasion of the overlying bone. Other benign tumors of the lacrimal gland are myoepithelioma, oncocytoma, Wathin's tumor, which are clinically having similar presentation of pleomorphic adenoma, but they are extremely rare, and their diagnoses are usually based on histopathological examination. Then we have the malignant tumors of the lacrimal gland, the most common of which is adenoid cystic carcinoma. Adenoid cystic carcinoma has a bimodal peak of incidence, that is either it can present in the second to third decade of life, or most commonly in the 6th decade of life, that is in the elderly. So in this picture we can see that this is a patient in the elderly age group having a lesion which is irregular with irregular surfaces and overlying skin changes. We can see dilated vessels are present, regions of conjunctival chemosis as well as hemorrhage, and usually these patients present with pain mainly due to perineural invasion of the tumor, and CT findings would be that of a irregular mass which is seen in the with irregular borders, and there can also be features of bone erosion which is almost seen in 75% of cases of adenoid cystic carcinoma, and features like bone destruction as well as calcification. Other tumors can be a malignant mixed tumor, which is due to the malignant transformation of a pleomorphic adenoma, and that is also a rare entity. And in that case, it is usually occurring in a long-standing pleomorphic adenoma, and other bone and soft tissue involvement would be seen. Other malignant tumor of lacrimal gland is an adenocarcinoma, which has a similar presentation as that of an adenoid cystic carcinoma. But in adenocarcinoma, there is early lymph node involvement because it is usually lymphatic spread. Other differential diagnosis of lacrimal gland tumor would be inflammatory lesions of the lacrimal gland. It could either be a idiopathic inflammatory pseudotumor or infectious dacroadenitis, or even cases of chronic bilateral dacroadenitis and also sarcoidosis. It will have a similar presentation, but the features that goes against is that in our patient there was no features of pain or swelling or lid edema, which is usually seen in cases of inflammatory tumors of the lacrimal gland. And CT findings would also be with no body changes, or there will be lesions with diffuse mass with ill-defined margins. And other lesion which we have to consider in lacrimal gland would be a lymphoproliferative lesion of the lacrimal gland. Most common is the extranodal marginal B cell lymphomas. They also have a bimodal presentation, and it is common in the third as well as sixth decade of life. They are usually bilateral, and they can have characteristic salmon colored patch in the supralateral cul-de-sac, and the mass is usually rubbery, and they have on CT, we will be able to find homogeneous lesion with indistinct borders, molding with characteristic molding against the globe or the orbit. Also, a solitary fibrous tumor of lacrimal gland have been reported. That is a rare spindle cell neoplasm, and it can mimic presentation of a pleomorphic adenoma. So we had with all these DDs in mind, we had gone ahead with the right lateral orbitotomy with tumor excision under GA, and intraoperatively we were able to find a mass of about 2.5 into 2 centimeter in dimension, and the palpebral part of the lacrimal gland appeared normal. So in these cases, we have various approaches to reach to the orbit, and the decision regarding the approach would depend upon the site of the tumor as well as on the size and involvement of the tumor. In lacrimal gland tumors, we usually prefer the lateral approach, either using a stellar right incision which is extending from the brow to the lateral part of the eye, or a modified stellar right which is from the lid crease to the lateral aspect, or a Burkitt's Cronlin which is a horizontal incision. So these lateral orbitotomy is usually preferred in cases of lacrimal gland tumors. So the steps in the surgery, it is usually done under general anesthesia. An adequate size S-shaped lid crease incision is made. Soft tissue dissection and posterior periosteal incision parallel to the lateral orbital rim is made. We can see that the soft tissue is being dissected, and then the periosteum is elevated using a periosteum elevator, and blunt dissection is done to delineate the mass, and all the additions of the mass from the Wittnall's ligament as well as the Wittnall tubercle is cut, and the mass is removed in toto using a cryoprobe. And also a part of the palpebral part of the gland was also removed, though we found it was to be normal. A part of it was also removed, a drain was placed, and incision was closed with 6-0 cell. So this is the post-operative picture of the patient, and we had given him topical antibiotics as well as lubricants and a course of oral antibiotics for a period of 1 week. And histopathological report was obtained after 3 days, and it confirmed the diagnosis of a pleomorphic adenoma of right side and of size 20 into 12 millimeter, and there was no evidence of malignancy. So lacrimal gland is located in the lacrimal fossa of the orbital part of the lacrimal bone, and it has two parts, a large orbital part and a small palpebral part. It is divided by the aponeurosis of the levator palpebrae muscle. The orbital part is enclosed by the lacrimal fossa superiorly and inferiorly by the aponeurosis, and laterally and anteriorly we can see that the orbital septum is here, present, and at which point it is easily assessed, reached surgically. Palpebral part lies under the aponeurosis of the levator over the conjunctiva in the superior fornix, and the gland has a pseudocapsule which is derived from the periorbita. Wittnall's ligament as well as the levator aponeurosis provide the support to the gland, and the gland has a pinkish gray appearance, and which helps us to distinguish it from orbital fat, both by color as well as the consistency. There are accessory lacrimal glands also, like glands of Crow's, glands of Wolfring, and as well as rudimentary glands that are present in the caruncle, Prica semilunaris, as well as the infraorbital region. So lacrimal gland tumors have been classified in the year 1971, and this is the age-old 50-50 rule, which is followed, which shows that the lacrimal gland tumors can either be epithelial or non-epithelial. and the epithelial is around 50% and non-epithelial is also around 50%. The most common epithelial tumor of the lacrimal gland is benign tumor pleomorphic adenoma, which accounts for about 50%, and the rest 50% would be the malignant tumors, of which adenoid cystic carcinoma is the most common, which accounts for about 50%. But in recent years, we have seen that there is a deviation in the 50-50 rule, and there is more incidence of non-epithelial tumors, and of which the inflammatory tumors are about 64%. So going on to pleomorphic adenoma, it is also known as benign mixed tumor. It is known as a mixed tumor because it has components of both epithelial as well as mesodermal elements. It is the most common benign neoplasm, occurs in the 4th to 5th decade of life, and causes painless progressive proptosis. And usually we would be able to palpate a non-tender mass in the supratemporal quadrant in most cases, and usually the orbital part of the lacrimal gland is not involved. Only in 10% of cases the palpebral part is involved, and in that case freely mobile and lesion would be seen, and that would not produce proptosis or any bony changes. So this is the pathological gross feature of the lesion. It is grayish. It is a grayish white tumor with solitary, and the surface has bocellations, as well as they have found to have small projections which occur beyond the tumor surface, and the lesion is well circumscribed by a thin pseudo capsule due to the compressed adjacent tissue. On histopathological examination, as I've already mentioned, it is a mixed tumor. It has both epithelial as well as mesenchymal elements. So epithelial, benign epithelial cells are arranged as a double layer forming ducts, and we can also see the myxoid elements, and spindle cells are seen in the loose stroma. There can be areas of focal squamous metaplasia also present. On radiological in radiographic findings could be on ultrasonography, we can find a round to oval mass with medium to high reflectivity and regular internal structure. On CT scan, the lesion is well defined, round to oval, homogeneous lesion, smooth in outline, and associated with prominent lacrimal fossa formation. And this because of the fossa formation is usually because of the benign nature of the tumor, which is causing bone remodeling, and there can be in long standing lesions there can be lobulations as well as cystic degenerations. On MRI, the tumor is hypointense on T1 weighted imaging and hyperintense on T2 weighted. The management of pleomorphic adenoma is complete excision of the tumor with intact capsule without antecedent biopsy. It is important to remove the lesion while maintaining the intact pseudocapsule, as the tumors have high recurrence rate following incomplete excision or incisional biopsy. So incisional biopsy is avoided in cases of pleomorphic adenoma. The 5-year recurrence rate of completely excised tumor is 3%, whereas in cases of incompletely excised tumors, it can go up to 32%. And in these cases of recurrent pleomorphic adenoma, malignant transformation is about 10%. So it is important to remove the lesion completely with intact pseudocapsule. And in cases where an incisional biopsy was done and the diagnosis have come out to be a pleomorphic adenoma, it is important to remove the biopsy tract as well as the skin scar are excised incomplete with the total removal of the lacrimal gland. So an anterior orbitotomy approach is not recommended because this can lead to subtotal or piecemeal removal of the lesion. Also, small tumor excrescences are usually seen extending through the pseudocapsule, and it is important to remove a small amount of normal tissue surrounding the lesion so that we can take care of these small tumor excrescence as well. And in cases of a palpebral lobe lesion, we can go ahead with a isolated dacryoadenectomy via a transcutaneous or a transconjunctival approach. So they have Say and Folberg et al. Have also described a method of doing incisional biopsy in cases where we have a diagnostic dilemma, where we are not sure about the diagnosis of a pleomorphic adenoma or differentiate it between a benign or a malignant lesion. So they have suggested covering the incision site with several drops of biologically inert uh, butyl 2 cyanoacrylate. The cyanoacrylate glue serves as an extension of the tumor capsule, and the biopsy specimen is then submitted for fusion section. If the diagnosis comes out to be a pleomorphic adenoma, then we can go ahead with the lateral orbitotomy, and the complete en bloc removal of the tumor can be done. So this is a study from our center done under Professor Dr. Neelam Pushkar ma'am. They have described an entity called a cystic pleomorphic adenoma. So they have taken a total of 6 cases where there were presence of cystic spaces within the tumor. We can see that in this patient there is a supratemporal lesion which is seen here, and on radiographic imaging we could see that the lesion is well circumscribed but has areas of cystic changes, and there is no infiltration of there is no involvement of the bone. In such cases the diagnosis can be misleading, and on histopathological examination it had come out to be a pleomorphic adenoma. So they have described it in cases of long standing pleomorphic adenoma. There can be a cystic degeneration, and in such cases have an increased risk of rupture as well as a risk of incomplete removal. They have attributed this cystic change to the squamous metaplasia of the tumor cells as well as intratumoral hemorrhage or necrosis, which has led to the cystic appearance on imaging. Thank you.
Okay, is Vaibhav around?
Yes, ma'am.
He presented the case today.
Yes, ma'am.
Yeah. Vaibhav, I have a question for you. So you presented this case and you gave us the differentials first and then came to the clinical diagnosis. Actually, it has to be reverse. You have to first make a clinical diagnosis. So it should have been, and then order the investigations based on your differential. And then you come on to the final diagnosis. So I think that has to be very clear. Just like you do for uveitis, you make a diagnosis of anterior uveitis or pan uveitis or posterior uveitis, and then you order a set of investigations, and then you come on to the single diagnosis after you've made a differential. So your clinical diagnosis should have been that this was a case of abaxial proptosis with downward dystopia of the globe.
Yes, ma'am.
And then, of course, you would have given your differentials, and your investigations would follow depending on what differentials you have in mind. And then you make or you come to one or two diagnoses which are most likely based on your imaging. Okay, so that was one thing that I wanted to point out in your presentation today.
Okay.
So can someone tell us the on-face signs of proptosis? So if someone has a proptosis, how would it manifest on face or when you see the patient from front? What is it that you're going to note? You can put the picture of this photo of this patient. That would make it quite obvious. Yeah, can someone tell us? In this case, of course, there is a lot of globe dystopia as well. But if you would see this patient and if there was no dystopia, how or what would make you think of a proptosis in any given case?
Lid retraction and scleral show,
Yeah,
we can see.
which lid?
Upper lid retraction and inferior scleral show will
Yes.
point
Yes.
towards
So
proptosis.
usually it is the lower lid. You see the scleral show at the lower limbus, and that is usually the first sign of a proptosis. What else?
एक्सपोजर केराटोपैथी
Okay, that you can see it in this case. So apart from the scleral show, what else when you see you're examining a patient and you see it, and you may not do Navsegas in all patients, and sometimes in a busy clinic or a OPD you're just seeing the patient on face. So if you see a scleral show, you definitely must do a Navsegas test to look for proptosis. What else can you do? Or what else should you be looking for?
Ma'am, we can pay attention to the corneal reflex also. It can reveal mild globe dystopia.
All right. But before that, like in this case also, if you notice the horizontal palpebral aperture size is increased. All right. So not only is it a vertical retraction of the lower lid, but in long-standing cases, you may have a horizontal increase in the length. So then you're suspecting, and then you do an abscess and you see there's a proptosis. So can anyone tell us the various types of, or I think we are running into the next presentation. I just wanted to ask one thing, and this is for Shilpa. Shilpa, why did we do a non-contrast CT in this case?
Ma'am, we were suspecting a benign lesion, and we had to see the bone involvement, ma'am.
Okay. See, normally whenever you are thinking of a tumor, all right, whether benign or malignant, you would always want a contrast study. Unless you already have a MRI for that patient and all you want to see is the bone changes. In those cases, of course, you will go and get a NCCT done, but in that case, you must also show the MRI films of that patient for the soft tissue component. Okay?
I think we can move on to next
Sure, sure.
presentation.
Please go ahead.
Good afternoon, everyone. This is Dr. Tanvi, Senior Resident, Unit 6. So today we are presenting a case, and our presenters are Dr. Shruti Sapkal, 3rd SEM Junior Resident, and Dr. Madhu, 4th SEM Junior Resident. And I'm the moderator, and our preceptor is Dr. Nupur Gupta ma'am. So now over to Shruti to start the presentation.
Respected faculty and my dear colleagues, a very good evening to everyone. Today I'll be discussing the history part and the history examination and the initial management part of this case. So a 27-year-old female patient presented to RP center with chief complaints of diminution of vision in both eyes since 2 months. The diminution of vision was sudden in onset, it was gradually progressing, it was associated with pain, redness, severe photophobia and watering. It was not associated with floaters, flashes, colored halos, or there was no diurnal variation in the symptoms. There was no history of trauma or any ocular surgery in past. The patient had history of pot spine 10 years back, and she had received full course of antitubercular treatment for 12 months. She had history of malar rash over face, photosensitivity, recurrent mouth ulcers, and hair loss since 7 years. She had history of allergy to dust since 3 years, for which she was taking anti-allergic medications. There was no history of joint pains, chronic cough, or ENT problems, or genital ulcers. No similar history. Similar complaints were no history of similar complaints was seen in her family. In general physical examination, malar rash was present over face, partial alopecia was present, healed mouth ulcers were present, and rest of the general physical examination was within normal limit. Systemic examination of the patient was within normal limit. In ocular examination, the uncorrected visual acuity in right eye was 6/12, in left eye it was 6/18. The near vision in right eye was N8, in left eye it was N12. We were not able to perform the pinhole vision and refraction for this patient as the patient had severe photophobia. In diffuse light examination, the eyeballs were normal in size and shape. Both the eyeballs were normal in size and shape. They were orthophoric, and in all 9 gazes, the bilateral eye movements were normal. In eyelid examination, narrow palpebral aperture was noted in both the eyes. The lacrimal drainage system was within normal limit. In conjunctival examination, mild diffuse congestion was seen in both the eyes. In corneal examination, corneal perforation was present in both the eyes, In right eye, it was of size 3 millimeter by 3 millimeter. In left eye, it was by 2.5 millimeter by 3.5 millimeter, and iris tissue was prolapsing out through the perforation and was plugging the perforation site. The perforation was present in the paracentral region in the inferior nasal part of cornea. Then mild corneal thinning was present in the inferior part of cornea. It was crescentic in shape. It was associated with vascularization and scarring. Then the sclera was normal, and it was not associated scleritis was not there. Anterior chamber was shallow inferiorly, and 1+ cells were present in both the eyes. Then iris was brown in color. Pupil was irregular, eccentric, and it was not reacting to it was mildly sluggishly reacting to light, because iris tissue was prolapsing out of the perforation and the patient was on cycloplegic. Lens was clear in both the eyes, media was clear in both the eyes, and intraocular pressure was digitally low. We were not able to perform direct and indirect ophthalmoscopy for this patient because of photophobia. So for posterior segment examination, we performed USG, and it was anechoic in both eyes. To rule out various systemic causes, we performed detailed systemic investigations for this patient. To rule out TB, Montu test was done, and 10 millimeter induration was present. Chest X-ray was normal. There was no cavitation. Quantiferon TB gold test was negative. X-ray sacroiliac region was done to check for active foci of port spine, but no active foci were seen. CBC was within normal limit. ESR was raised. Rest of the blood investigations like LFT, KFT, TFT, RBS were within normal limit. Serum viral markers were negative. VDRL was negative. Serum ACE levels to look for sarcoidosis were normal. Serum ANA, serum anti-DS DNA to look for SLE were negative. Rheumatoid factor was negative. HLA-B27 to look for reactive arthritis was negative. Urine routine microscopy was within normal limit. C ANCA, P ANCA levels to look for vasculitis, vaginous granulomatosis were negative. Then in systemic workup, we sought various consultations. In medicine and orthopedic consultation was sought in view of history of port spine, but no active lesions were noted, and clearance was given for use of systemic steroids. Rheumatology consultation was sought for associated autoimmune diseases, but no definitive diagnosis could be made. But due to high clinical suspicion of SLE, tablet hydroxychloroquine 50 mg OD was started. Dermatology consultation was sought for malar rash. It was diagnosed as photodermatitis, and an emollient SPF cream was prescribed. So after history and examination, we reached clinical diagnosis of both eye peripheral ulcerative keratitis with uveal tissue prolapse, which in our case can be associated with systemic lupus erythematosus or Murren's ulcer or query associated with port spine. So medical treatment for the patient was started. Topical antibiotic was given 2 hourly, then topical cycloplegic, topical steroid was given 6 times a day, topical anti-glaucoma medication to prevent further iris tissue prolapse and to prevent corneal decompensation. Then topical immunosuppressant cyclosporin was given BD. Then lubricants were given. In systemic medication, tablet doxycycline was given for MGD and for its antiprotease activity. Then tablet hydroxychloroquine 50 mg OD was given for 2 weeks as per rheumatology consultation. Tablet vitamin C, tablet prednisolone 50 mg OD was given, which was tapered by 10 mg every week. Tablet acetazolamide again to lower IOP. Tablet pantoprazole was given. Then the patient was given medical management for approximately 10 days, and over 10 days with medical management, improvement in signs and symptoms was noted, like reduced congestion, and the patient was also more comfortable after the medical management. And similarly, these are the serial pre-op clinical photographs of the left eye also, and similar improvement was seen. This is the pre-op ASOCT that we performed for surgical management of the patient, and in this, as you can see, iris tissue is prolapsing out of the perforation and plugging the perforation site. And this is the superior part where corneal thickness is 591 micron, and in this inferior part you can see there is scarring and the corneal thickness is reduced, but it is comparatively, it is not that thinner. So we planned for bilateral circular corneal patch graft with amniotic membrane transplantation under LA in both the eyes, and we did not go for crescentic patch graft because in inferior cornea was of adequate thickness and it was scarred and vascularized. So left eye was operated first on 19 January 2021, followed by right eye on 22nd January 2021. So these are the images from surgical video of the patient, and they are depicting some surgical steps. Here, as you can see, we made host corneal button by using 3.5 millimeter dermatome punch around the perforation site. After this, the full thickness corneal button was excised by using curved corneal scissors. Then donor tissue was cut by using 4 millimeter dermatome punch, and it was sutured to the host cornea by using 10-0 monofilament suture. And when the patch graft suturing was completed, the sutures were buried. Then AMG was placed over the graft in overlay fashion, and AMG was secured in place by using fibrin glue. And after this, it was covered with BCL. AC was formed with air. Same post-operative treatment was continued. Just tablet hydroxychloroquine was stopped because definitive diagnosis of SLE was not made, and as per repeat rheumatology consultation, it was asked to be discontinued and then follow up in rheumatology OPD. So in the post-operative day 1 in right eye, as you can see, watery discharge was there, mild diffuse congestion was there, visual acuity, best corrected visual acuity was 6/60 with PR accurate in all 4 quadrants. The graft host junction was well opposed, there was no leak, all the sutures were intact and buried. BCL was in C2, AMG was in place, AC was well formed, air bubble was present, it was stable, pupil was central, lens was clear, IOP was digitally normal, and fundus, hazy glow was seen on fundus. This was the post-op ASOCT of right eye. As you can see here, the graft host junction is well opposed, and this is the BCL. Similarly, in left eye, watery discharge was there, diffuse congestion was there. The graft host junction was well opposed. The best corrected visual acuity was 6/60 with accurate PR in all 4 quadrants, and hazy glow was seen on fundus. On subsequent follow-up, when the patient came to us after 2 weeks, this is the clinical picture that was captured. The AMG was in place, the BCL was there, which was removed after 2 weeks and replaced. The sutures were intact and buried, and the best corrected visual acuity was 6/18 with PR accurate in all 4 quadrants. In the left eye also, AMG was present, the graft host junction was intact, and best corrected visual acuity was 6/24 with PR accurate in all 4 quadrants. Thank you. Further discussion will be continued by Dr. Madhu.
Good evening, everyone. I'll be continuing the discussion. So, as we discussed, we came to the diagnosis of both eye peripheral ulcerative keratitis with uveal tissue prolapse, and we were considering association with systemic lupus erythematosus, Moran's ulcer, and port spine. So, what is PUK? Peripheral ulcerative keratitis is a form of crescent-shaped stromal inflammation which involves the juxtalimbal cornea, and it is characterized by sectoral thinning of the affected area. It is always associated with an overlying epithelial defect, and there is progressive loss of corneal stroma. The most common disorders associated with PUK are systemic collagen vascular diseases, of which rheumatoid arthritis is the most common, and it accounts for 34% of non-infectious causes. So causes can be both ocular and systemic. Local pathology might be infective and non-infective. Infective causes include bacterial infection, viral infection, amoebic and fungal infections. Non-infective ocular causes may be traumatic, chemical injury, thermal burns, radiation burn, abnormalities of eyelids, local autoimmune responses, and neurotrophic keratitis. Systemic causes can be either infective and non-infective. In non-infective causes, most important is autoimmune vasculitic diseases, rheumatoid arthritis, SLE, PAN, vaginous granulomatosis are important ones. And there may be association with dermatological disorders, IBD, malignancy. And infective causes being tuberculosis, syphilis, gonorrhea, and viral being AIDS and hepatitis are the important ones. So how does this occur? The exact pathophysiologic mechanism of PUK is unclear, and the research suggests that both humoral and cell-mediated autoimmune responses are involved. So there are three implicated mechanisms. One, reaction to corneal antigens, and circulating immune complex deposition, hypersensitivity reaction to exogenous antigens. So how does the ulcer occur in these cases? So first, there is deposition of immune complexes, which activates the classical pathway of complement system. So this recruits inflammatory cells from in the peripheral cornea, and these cells releases certain enzymes like collagenases and proteases, which cause destruction of corneal stroma and form the ulcer. So how do they present to us? Common symptoms include pain, watering, photophobia, and decreased vision. So coming back to our case, it had all these symptoms, and signs we were able to see were corneal opacity, crescent-shaped corneal ulcers, varying degree of vascularization, corneal thinning is most important, and it may complicate to perforation. Scleritis was not seen in this case, in our case, and it is almost always seen with vaginous granulomatosis. So differentials we kept for our case was PUK associated with SLE, Moran's ulcer, and PUK associated with tuberculosis. So what how a case of PUK associated with SLE presents? They are usually middle-aged females. Systemic features include malar rash, alopecia, photosensitivity. All three were there in our case. Other features, systemic features include Raynaud's phenomenon, proteinuria, pleuritis, pericarditis, anemia, and thrombocytopenia. On blood investigation, we can see ANA and anti-dsDNA antibodies, which were not there in our case. What is Moran's ulcer? Moran's ulcer is a form of PUK, which is not associated with scleritis. It is idiopathic and occurs at any age, but most number of cases are found in patients over 40 years. It begins in the peripheral cornea and spreads circumferentially and centrally. The main difference from PUK is the severity of pain, which is more intolerable in Moran's ulcer. It may involve one of the both eye, that is, it can be unilateral or bilateral. The central border exhibits an overhanging head, which is a typical feature. Unlike in PUK, the sclera is also very rarely involved. PUK can also be associated with tuberculosis. Our patient had history of port spine, but X-ray and blood investigations that we conducted ruled out any active foci of infection. So how do we treat this condition? Treatment of PUK is based on severity and findings. Treatments initiated for systemic autoimmune diseases have beneficial effects on ocular manifestation. So we have to treat the systemic condition. Our goal was for the treatment of medical treatment of ocular disease was to reduce inflammation, promote epithelial healing, and minimize the stromal loss which was happening. So we started the patient on local bacterial antimicrobial treatment. So local antibacterial and viral infection that cause PUK are treated with antimicrobials. Preservative-free lubricating agents are advised to tackle the associated dry eye and for removing the dilating inflammatory mediators on the ocular surface. Topical corticosteroids were also started, and which should be tapered according to the clinical response. Eyelid hygiene should be explained. Cycloplegics should be used to relieve the pain. Oral tetracycline derivatives provides additional benefit in preventing further stromal loss by decreasing the protease activity. In our case, we use doxycycline. Coming to the systemic immune modulation, glucocorticoids are the first line therapy in acute cases of PUK. Usually the starting dose is 1 milligram per kg per day and maximum up to 60 milligram per day, followed by a tapering schedule based on the clinical response. We can use immunosuppressives or biologics in cases of refractory to glucocorticoids or as steroid sparing agents, but we should consider the common complication which will happen like osteoporosis, exacerbation of hypertension and diabetes, electrolyte imbalances, and gastrointestinal bleeding. Immunosuppressive options do we have are antimetabolites, methotrexate, azathioprine, mycophenolate mofetil, and leflunomide. Alkylating agents being cyclophosphamide, chlorambucil, T-cell inhibitors, biologic agents being infliximab, etanercept, and rituximab are approved for this condition. Coming to the surgical management, we can try tissue adhesive and bandage contact lens if the perforation is very small. Conjunctival resection can decrease the immunologic load which happen around the limbus, and amniotic membrane transplantation can be tried. Lamellar patch graft if there is no perforation, if there is no full thickness involvement. Tectonic PK or patch graft can be tried, which we did for our case. We followed a stepwise treatment approach, which says that for unilateral Morans and in bilateral we can start on topical steroids, and in bilateral cases we can consider going for oral corticosteroids, and we can try conjunctival resection. If bilateral cases are not responding to this conventional therapy of steroids, we can start on systemic immunosuppression. And additionally, in resistant cases, and if there is an impending or frank perforation, we can think of going ahead with surgery, which we did for our patient. And in follow-up, we can rehabilitate the patient for giving them the best corrected visual acuity. So what are the messages we are going to take from this class? PUK includes a group of corneal infections and inflammatory diseases that usually result in peripheral corneal thinning. Inflammatory causes are usually associated with life-threatening autoimmune collagen vascular diseases. So we have to take a detailed history of the patient, and PUK might sometimes be the initial sign of systemic disease. That's why we have to work up very meticulously. Limbal and conjunctival vessels are more prone to deposition of circulating immune complexes. Rheumatoid arthritis is the most frequent underlying disease, so it has to be ruled out first when we are thinking of systemic causes. The mainstay of treatment is not only controlling the inflammation involved in the ocular tissue, but also including controlling the underlying systemic vasculitic disease. We have to keep the patients on close follow-ups, and patient might need to get repeated blood investigations done to look for recurrences and other complications. Early accurate diagnosis and prompt systemic treatment can be life-saving to the patient. Thank you.
Thank you, Madhu and Shruti. Very nicely presented. Does anybody have any questions? And Tanvi, can you sum up the case? And basically, it looks very simple presenting here how it all evolved. Like a jigsaw puzzle, everything fell into place. The patient had a good outcome. But PUK cases of PUK are actually very challenging. One to diagnose. Then diagnosis you can do. You know what a PUK looks like. It's a peripheral ulcer. Can anybody tell us the difference between a furrow degeneration and a patient of PUK? How will you differentiate? Shruti?
No inflammation. Ma'am, can you please repeat the question?
I'm asking if you have a patient with a peripheral melt, how would you diagnose that it is PUK or it's a furrow degeneration? It's an elderly male, and you have a precentric melt of the superior cornea or the inferior cornea. How would you diagnose whether it is peripheral ulcerative keratitis or a furrow degeneration, which is a normal degeneration?
First thing to look.
PUK will
What will clinch the diagnosis?
Ma'am, first thing to look for is the inflammation, active inflammation which is undergoing in PUK, and in cases of degeneration, which.
How would you pick up active inflammation? You're not doing any test here, no?
Yes, ma'am.
So
There may be associated scleritis or conjunctivitis or limbitis can be seen.
what one test would clinch the diagnosis? What will happen on fluorescein staining?
Ma'am,
And there won't be any epithelial defect in a furrow degeneration.
Yes.
Whereas in a PUK, there.
Yes, that is the basic difference. That's a degeneration and this is an active inflammation. So that is how you pick up. And I think there are quite a few questions. So what I was saying was, one is the diagnosis, that is maybe easy, but the underlying etiology to manage the case is very important and crucial. So whether you have to exclude all the diseases, the local and the systemic diseases which lead to PUK, and then maybe come into a diagnosis of Murren's ulcer. In our case, though it was managed quite well, we still do not know the exact diagnosis. It could have been malignant Murren's of the young, which is bilateral and does it is more likely because in SLE usually you may have scleritis as well, but it could be a latent SLE which is not being diagnosed by the ANF factors, which is very sensitive. You may have to do a renal biopsy for the patient to have a conclusive evidence. But of course, you can follow up the patient, and the correct approach was to add or start the systemic immunosuppressant by the rheumatologist. In fact, these pictures that you're seeing is after the hydroxychloroquine was started. The patient was so photophobic, you could not have any picture. So then the eye was very inflamed, and after control of the inflammation with the hydroxychloroquine, then we could actually plan a surgical management and have actually a good outcome with the surgical management. So there are 2-3 points I want to point out. Shruti, you said we started timolol for as a prophylaxis for corneal decompensation.
No, ma'am. Sorry.
Is that true?
No, ma'am.
So what did we start the anti-glaucoma medication for?
Ma'am, there was uveal tissue prolapse. So just to prevent further uveal tissue prolapse, to reduce the IOP, we started anti-glaucoma medication.
Yes. So there are a few questions.
Yes, ma'am. So there are a few questions I would like to answer. Dr. Abhijit has asked, would conjunctival recession have helped in this case? No, I don't think, because in our case, the inferior crescentic area was already scarred and vascularized, so there was no such active inflammation in that zone. And in our case, there was a full thickness perforation. So our main aim was to do a tectonic thing for that area. So we performed a patch graft. And I don't think conjunctival recession would have helped in this case. And the patient was already responding to medical treatment also. The congestion was reduced and the patient's symptoms also reduced with medical treatment. So there was no role of conjunctival recession. It has a controversial role also. And then Dr. Anuja Patil has asked, do we need all investigations in PUK patients? Usually we do all the investigations. They can be tailored according to the systemic symptoms of the patient. But yes, because if we want to diagnose Murren's ulcer, it is basically a diagnosis of exclusion. We want to diagnose the associated systemic pathologies because in 50% of cases, PUK can be associated with systemic autoimmune diseases, and the treatment would then depend upon the systemic autoimmune disease, because that systemic treatment would also help in ocular treatment. So it is important for that. Why was hydroxychloroquine started? Dr. Priyadarshana has started. Dr. Priyadarshana has asked. Hydroxychloroquine was started by the rheumatology department people. We did not start it. They started on the basis of suspicion of SLE, as there was malar rash. She was a young aged female, and there was photosensitivity also and mouth ulcers also. Although the blood investigations ruled out SLE, but the blood investigations are not always sensitive and specific. So maybe she can later develop the full features of SLE in the future course of the disease. Dr. Sumant has asked, why was AMG used in addition to patch graft? AMG was used because AMG has several growth factors and anti-inflammatory factors. So it was added to reduce the inflammation in that area and also to protect our patch graft and to promote healing in that area. Dr. Shilpa has asked, should we wait and do medical management even in perforated PUKs? No. If there is a full thickness perforation with uveal tissue prolapse, that is a pathway for infective organisms to go inside the eye and can cause endophthalmitis or infective keratitis. So in perforated PUKs, we start medical therapy, obviously, to reduce the inflammation, but the management will be surgical only. We have to do surgery for that perforated part. Depending upon, we can do a lamellar patch graft, a full thickness patch graft accordingly, or a glue BCL just for a small perforation. Are there any chances of further corneal melt in these patients? Dr. Jackie has asked. Yes, there are further chances of corneal melt because we have to control the systemic inflammation, whatever is going in the body. So that's why the systemic treatment is very important. And it is a known fact that the patch grafts or keratoplasties after a PUK have a very less chance of survival. Actually, they are considered as higher risk grafts and they have a chance of graft rejection or corneal melt in future also. We have to keep the patient on follow-up accordingly.
Is that all, Tanvir?
Yes, ma'am. These are all the questions. Yes, ma'am.
Okay. Does anybody else want to comment? I think ma'am is there, Dr. Vanati or
No, I don't think there are any further questions. I think we can conclude here.
Thank you, sir.
Okay,
thank you, Dr. Nuku, ma'am, and thank you everyone for attending the class.
Tanvir, there is a question from Abhijit about the indication of conjunctival recession. I think you can conclude after answering this.
Yes. So according to the stepwise approach, that stepwise approach was originally described in 1984. That is basically for Murren's ulcer. Conjunctival recession we can do if there is an active inflammation which is not responding to topical or oral corticosteroids. So it is usually done before other surgical managements. Although it has a controversial role, some people say it has a benefit and some people don't. But yes, it can be done in cases of active inflammation where you want to recess the conjunctiva to reduce the load of inflammatory cells reaching the cornea. I think